Assalamu alaikum warahmatullah. Today we are going to discuss how to approach a case of systemic sclerosis in MRCP basis exam station 5. As we know that station 5 is 10 minutes, 8 minutes with the patient and 2 minutes with the examiner. The case of focus the history, focus the examination and replying the patient concern. Scenario of systemic sclerosis can come in the scenario of difficulty of swallowing because of esophageal dysmotility of the patient, or maybe shortness of breath because of lung fibrosis, pulmonary hypertension, and restrictive cardiomyopathy, or maybe pain in both hands because of Raynaud's phenomena. But most commonly, the patient is coming in the presentation of a scenario of difficulty with swallowing. Okay, before going to how to approach the case of systemic sclerosis, let's to rapidly to review the systemic affection or the systemic involvement of a case of systemic sclerosis. We will start with the hands. The hands of this patient will has tight, shiny skin, scleroductally, and maybe Raynaud's phenomena. So in the history, you have to ask about any finger color changes when exposed to cold weather. There's the hands of systemic sclerosis. Then from up downwards, we will start from the head. The face of the patient like that, like we see in this picture, this beautiful woman. She has small mouth, pinched nose, microglossia, and maybe some skin changes in the form of telangiectasia, or maybe morphia, or maybe erythema, uh, and also maybe some skin changes in the form of scarring, or livido reticularis, or maybe alopecia. So this is the head of the patient. We will start from upward or from the head downwards. The patient has pinched nose, small mouth, tight skin here, and the skin changes in the form of most probably telangiectasia, livido reticularis, morphia, or maybe scarring or alopecia. Then downwards, we'll find this patient lung. What the lung affection or lung involvement in systemic sclerosis, this patient may came in the form of a lung affection of lung fibrosis, basal lung fibrosis, or pulmonary hypertension due to lung fibrosis. Then the heart of this patient can be involved in the form of restrictive cardiomyopathy or maybe conduction defect. Then the abdomen of the patient can be involved in the form of esophageal dysmotility, or maybe also of bacterial overgrowth due to esophageal dysmotility, maybe dysphagia or difficulty with swallowing because of esophageal dysmotility that we have to ask about in the history. Then the kidney of the patient can be involved in the form of severe hypertension or hypertensive crisis or renal crisis and glomerulonephritis, multiple types of glomerulonephritis. Okay, so this patient's skin can be affected in the form of tight shiny skin, skinny changes, like we said before, in the form of livido reticularis, and in the form of telangiectasia, morphia, scarring. Musculoskeletal system can be affected in the form of sclerodactyly, and we can add dryness phenomena in the cardiovascular system affection. Okay, so how to approach this case? Like any case before in station 5, focus the history, focus the examination, and replying the patient concept. Whatever the complaint of the patient, we have to ask about the onset and analysis of the complaint. This is number one, to analyze the complaint perfectly, onset of the complaint, course, duration, progression, worsening factors, improving factors, whatever the complaint. Then to ask about other systemic review related to systemic sclerosis. This is not a case of differential diagnosis actually, this is a straightforward case of systemic sclerosis to ask about the analysis of the complaint, then to ask about the systemic involvement in systemic sclerosis. Musculoskeletal system, any skinny changes, is it became tight than before, shiny, smooth, any skin rashes like telangiectasia and paper, any joint pain, any muscle pain. These four musculoskeletal symptoms. Respiratory symptoms, any cough, any shortness of breath because of lung fibrosis, cardiovascular system, any chest pain, any racing of heartbeats, any shortness of breath, any leg swelling, and if there anything positive with the symptoms, you have to do brief analysis about this symptom. Likely, um, if the patient has shortness of breath, for example, you have to ask about shortness of breath. When it started, is it increasing, decreasing, or the same? Is it coming all the time or coming on and off? Is it coming when you are laying down? Is it awakening you from sleeping, searching for air? Any finger color changes when exposed to cold weather? This is for the dryness phenomenon. GIT symptoms. We know that it has esophageal dysmotility and hypomotility, which can cause some bacterial overgrowth and difficulty of swallowing. So we have to ask about all the gastrointestinal system symptoms: any tummy pain, heartburn, feeling sick or getting sick, difficulty with swallowing. And if there is difficulty of swallowing, you have to do good analysis for difficulty of swallowing. Is it more to fluids or the solids? Is it coming on the initiation of swallowing or after initiation? To differentiate between oropharyngeal and esophageal dysmotility. Do you feel that the food particles getting stuck in your food pipe? And if yes, where exactly this food particle is stuck in your food pipe for esophageal dysmotility? Any loose motions or less motions for bacterial overgrowth secondary to dysmotility? Kidney or renal? Any kidney problem? Any kidney problem? What about your water work? What about the amount, the color in your urine? What about your blood pressure? Do you measure your blood pressure before? And if the patient has blood pressure, you have to ask the patient if it is controlled or not, and what medication the patient on for blood pressure. This is for renal crisis. Like that, we finished the systemic review related to systemic sclerosis. After that, we have to take history of the other overlapping syndrome or other mixed connective tissue disease, like in rheumatoid arthritis or SLE. We have to ask about other mixed connective tissue disease. Any joint pain, any cough, shortness of breath for rheumatoid arthritis, but we asked about cough and shortness of breath before, no need to ask again. Any falling of hair, mouth sores, facial rash for the urine, facial rash that increases with sun exposure for the urine, this is for SLE. Any difficulty of combing your hair or getting up from a chair, any muscle pain for polymyositis, any dry mouth or gritty eye sensation for jogging. Then, like every case in station 5, you have to ask about social history. The four questions that we know fixed for all the cases of station 5: communication skills and history taking, what the patient job, what the patient is doing for living, and how much his symptoms affect his job and his usual daily activities. Refer the patient to a social worker if his usual daily activities is affected. Refer the patient to occupational health care worker if his job is affected. With whom the patient is living and who is supporting the patient at home. Financial support, smoking and alcohol history. Medical history of long-standing disease. Family history of similar condition. Family history of similar condition or long-standing disease. What about your drug list? Then the examination. Okay, we'll take a case sample, which is the most common in the exam. This patient is Mrs. Nhala is 27 years old. She has been complaining of difficulty with swallowing for the last 2 months for your kind care. You have 5 minutes before going to the station. If you have a scenario of difficulty with swallowing, you have to think about uh, systemic sclerosis. You have to think about Graves' disease or neck lamp compressing the esophagus. Most probably it will be systemic sclerosis, but you have to put in your mind also it can be a case of neck lamp or Graves' disease compressing the esophagus, and the patient may be female patient which is wearing a scarf, and the neck lamp is not obvious for you. The history, of course, in these 5 minutes you have to prepare yourself well, and then go inside. Most probably, if you are not in England or in UK, you will have a surrogate with the patient. Maybe he will present you the surrogate like the patient um, daughter or the patient brother or the patient sister. Go inside, shake hands for the patient surrogate. Good morning, I'm Dr. Sadiq, Senior Health Officer of the Medical Department. Nice to meet you. Nice to meet you, Doctor. I'd like first to confirm that you are Mrs. Hind, sister of Mrs. Hala, 27 years old. Yes, Doctor, I'm the one. I have a letter from your GP that your sister has been complaining of difficulty with swallowing for the last 2 months. Is it right? Yes, Doctor. Can you tell me more about her condition, please? Yes, Doctor. My sister has been complaining of difficulty with swallowing for the last 4 months, which started gradually with here and decreasing more and more. Okay. Did it start gradually or suddenly? No, gradually, Doctor. Is it increasing, decreasing, or the same? No, increasing, Doctor. Is it coming on and off or all the time with hair? No, Doctor, most of the time with hair. Okay, I'm sorry for that. Okay, is it more for the solid foods or for the liquids? No, Doctor, it started with the liquids and now it is for more for both for the liquids and solids. Oh, I'm sorry for that. Okay, then take GIT, all GIT symptoms because the complaint is GIT, so that's check for the other all GIT symptoms. Any tummy pain at all? No, Doctor. Any heart pain? No, Doctor. Or sometimes there's heart pain. Any feeling sick or getting sick? No, Doctor. Okay. Uh, she notes that this food particles can stick in her food pipe. No, Doctor. Any loose motions or less motions? No, Doctor. Any vomiting out blood or blood in the stool? No, Doctor. Now I'm going to take the history of musculoskeletal system. Any skin rash at all? Yes, Doctor. She has some skin rashes. Where is the rash exactly in her body? The rash in the face, Doctor, and maybe in the arms and the hands as well. Can I take a look in this skin rash, please? You can act like you are taking a look for the rash. Do you notice anything that increases skin rash like exposure to sun, stress, smoking? Anything at all? No, doctor. Anything that relieve this rash? No, doctor. Any joint pain? No, doctor. Any muscle pain? No, doctor. She has maybe some joint pain in the hands, doctor, which is irritate here sometimes. Oh, I'm sorry for that. In both hands or one hand? In both hands, doctor. In all the hands or in the joints, small joints itself? No, on the joints itself, doctor. Oh, I'm sorry for that. Any history of cough? No, doctor. Coughing up blood, shortness of breath? Yes, doctor. Sometimes she's feeling this shortness of breath. This shortness of breath when it started exactly? Maybe 2 months back as well, doctor. Is it increasing, decreasing, or the same? No, increasing, doctor. Is it exertional or in rest? No, it is more with exertion, doctor. Do this short suppress awaken air from sleeping, searching for fresh air? No, doctor. Then cardiovascular system. Any chest pain? No, doctor. Any racing of heartbeats? No, doctor. Any leg swelling? No, doctor. Any finger color changes when exposed to cold weather? Yes, doctor. Sometimes she has this finger color changes when exposed to cold weather. Is it associated with pain as well? Yes, doctor. I'm sorry for that. GIT, you took the history of GIT already. No need to take it again. Renal. Any kidney problem at all? No, doctor. What about her water work? What about the amount? Any change in the amount or the color? No, doctor. Any frozen urine? No, doctor. What about her blood pressure? Yes, doctor. She has high blood pressure recently. Yes. She is taking any medication for high blood pressure? Yes, doctor. She is taking medication called captopril. How much is the dose she is taking? It's 25 per day, doctor. 25 milligram per day. Is it controlled? No, her GP told that it is not controlled, doctor. Oh, I'm sorry for that. Then I'm going to ask about other mixed connective tissue disease. I asked about all of these: any joint pain, short suppress on the cuff before rheumatoid, so no need to ask again. Any falling of hair or mouth sores or facial rash increase with sun exposure? No, doctor. Any frozen urine? No, doctor. Any difficulty of coming here or getting up from a chair or muscle pain or polymorphitis? No, doctor. Any dry mouth or gritty eye sensation or jogging? No, doctor. Social history. In this point, you can start examining the patient not to waste time. Because, social history, medical history, family history, and drug list is typical for all the cases. So you are only acting. What about what she's doing for a living? Yes, doctor, she's a secretary, doctor. And how much her symptoms affect her job and usual daily activities? Affecting so much, doctor, she has difficulty in dealing with the keyboard, doctor, and typing. Oh, I'm sorry for that. We can refer her to occupational care to give her the appropriate to solve any problem related to her job. It's okay? Yes, doctor. Okay, we can refer her also to a social worker if she has any social troubles at all. Okay? Yes, doctor. With whom she is living at home? She is living with her mother and the father, doctor. Anyone to support her at home? Yes, doctor. What about financial support? She is financially supported, doctor. Does she smoke at all? No, doctor. Does she drink alcohol? No, doctor. She has any medical illness of note like diabetes, hypertension, heart disease? No, doctor. Any family history of similar condition or diabetes, hypertension, long-standing disease? No, doctor. What about her drug list? She's taking captopril for hypertension, doctor, for the last 2 months. Okay. Anything else as a drug list? No, doctor. Oh, can I examine here, please? And then you start your examination. Like all the cases of uh, like all the cases involved in joint pain or polyarthropathy, it is fixed examination. Look, feel, and move for the hands. Look for the hand for any hand deformity, any scars, any pigmentations, any ulcers for sclerodactyly, and in fingers for rhinos. Finger for rhinos, you will see some maybe atrophic changes or ulcers or nearly changes for this vision. Feel the joints by palpation and for active synovitis, for wormness, and soreness for active synovitis. So joint palpation will compress the joints between our fingers slightly and to tell the patient if she felt any pain at any time, just to tell us, and to see if there is any soreness at all. And you can also palpate, or you can, put your dorsum aspect of the hand on the joints and on the forearms of the patient to compare the warmness. Move, this is for functional status of the patient. So move, you will assess the functional status by prayer sign, reverse prayer sign, picking up coins, fist compression, buttoning or unbuttoning, but only this is only three of these actions are needed, no more. This is in a case of the patient is affected by arthropathy and their sclerodactyly and their joint of the hands are affected. We can examine the aspect of the extensor aspect of the forearms by palpation with your dorsum aspect of the hand is for only use or electron impercy. Why? Because this patient may have rheumatoid, may has rheumatoid as overlapping. Then compare the skin of the arm and the forearm to differentiate between limited and diffuse scleroderma. We know that scleroderma may be diffuse or limited cutaneous scleroderma. You can pinch the skin of the forearm and the arm of the patient to see if there is involvement of the skin of the arm of the tight shiny skin as well, because if the if the arms are involved, it means that most probably this is a case of diffuse cutaneous scleroderma. Then examine the arms of the patient um, under resistance to see if there is proximal neuropathy, as polymyositis may be associated as overlapping. Examine the oral cavity for any mouth sores if you suspect overlapping systemic sclerosis. Then other systemic involvement of systemic sclerosis. The respiratory system, you have to put your stethoscope in the bipedal areas, bipedal lung fields for fine crepitations of lung fibrosis. Cardiovascular system examination for GVP if raised, GVP is raised or not, and they examine the heart, examine put your stethoscope in the heart, especially in the secondary pulmonary area to see if there is or to hear if there is any secondary pulmonary pulmonary component of the secondary of the second heart sound is loud or not, because in secondary pulmonary hypertension you will hear loud component of the second heart sound. Okay, what concern is the patient may ask in this case? What could be the cause, doctor, of my difficulty with swelling or my sister difficulty with swelling? Doctor, I appreciate your concern. Most probably, your sister has a disease called systemic sclerosis, which is a multi-system disease involving your food pipes causing this motility and difficulty with swallowing, and your small blood conduits of your fingers causing narrowing and coldness and color changes. Your lung is causing scarring and shortness of breath, and maybe also your heart and your kidneys may be involving causing your high blood pressure. So what you are going to do is to do further blood tests and imaging to confirm our diagnosis, and if confirmed, we are going to refer you to a multidisciplinary team involving rheumatologist or joint doctor, physiotherapist, social worker, psychiatrist to give you the appropriate plan of management. Is it curable condition, doctor? I'm sorry to tell you that it is not curable, but it can be controlled on medication. Any other concern? No, thank you. Then, after that discussion with the examiner may ask you, what's your clinical findings, doctor, for this case? This lady is underweight, for example. We will imagine the clinical findings because we don't have a case in front of us. So this patient is underweight and she has systemic sclerosis manifestation in the form of skinny changes, uh, skinny changes in the form of telangiectasia and erythema, and she has small mouth, microglossia, and pinched nose. She has also sclerodactyly and some finger changes in the form of trophic ulcers and needle changes. She has also bibasal lung fine crackles indicating lung fibrosis. I'd like to do urine dipstick for this patient for proteinuria, and I'd like to examine this patient blood pressure. Okay. There is no evidence of overlapping syndrome with this patient. Okay, and this patient seems to have a limited cutaneous scleroderma because there is sparing of the skin of the arms of the patient. Okay, what investigation you are going to do for this patient, doctor? I'm going to do investigation the form of basic investigation, CBC, electrolytes, kidney function, liver function, inflammatory markers, and autoimmune profile for the patient in the form of anti-centromere antibody, rheumatoid factor, anti-nuclear antibody, anti-CCL70, and anti-ribonuclear antibody, polymerase 1 and 2 and 3. And we have to do also anti-ribonuclear protein, anti-RNP antibody. This is for overlapping syndrome. I'd like also to do investigation for the systemic involvement for this patient by doing chest X-ray and maybe high resolution CT scan for lung fibrosis, echo ECG and echocardiography for the heart problem, urine analysis for renal problem or glomerulonephritis. Okay, what the treatment for this patient, doctor? This patient will need non-pharmacological treatment in the form of patient education and counseling, psychosocial support, occupational support, and if for his difficulty of swallowing or esophageal dysmotility, this patient need to receive um, some low residual diets and nutritional supplementation, and also prokinetic drugs like prokinetic drugs for this motility, proton pump inhibitors, and antibiotic for bacterial overgrowth. For his rhinos, this patient needs to stop smoking for his rhino, and stopping smoking has to be mentioned in the replying of the concern actually, because it may worsen his hand condition. So for rhinos, this patient need to stop smoking, and they give medication in the form of, and the hand warming also is warranted for the patient. Vasodilator drugs like uh, ACE inhibitor, calcium channel blockers, or prostaglandin analog, and also if not, if the condition is refractory, we can do sympathectomy in severe cases. Um, for his kidney problem, this patient need aggressive treatment for his hypertension by ACE inhibitor. And for respiratory problem, interstitial lung diseases, patient may need vasodilator therapy for his pulmonary hypertension in the form of uh, procyclin analogs or sildenafil, antifibrotic therapy for lung fibrosis in the form of deep insulin. This is what uh, all what questions may be asked in this case. Systemic sclerosis, which is very common and frequent case in the exam. Systemic sclerosis, which is most commonly coming in the form of or in the scenario of difficulty with swallowing, or maybe pain in both hands because of rhinos, or maybe shortness of breath because of lung fibrosis and pulmonary hypertension and restrictive cardiomyopathy. Thank you, and see you in the next stations, inshallah.